Our lecture today will be about peripheral IV cannulation and intraosseous access, and this is the objectives that it will be covered by the lecture. We will start with the peripheral IV cannulation. First, the indications. We will need IV access for the fluid and electrolyte replacement, administration of medication, administration of blood and blood products, and administration of total parenteral nutrition. The advantages of using IV access is by gaining IV access, the delivering of medication or agent enters straight into the bloodstream, so it will allow immediate effect. And also the intravenous access, it will help gain some control over the rate of administration or intake of the agent in the best possible manner rather than oral routes. Also, it will prevent patient from pain and trauma due to repetitive pricks by subcutaneous or intramuscular route. And also when patient is not able to take any medication orally in cases of vomiting or the patient is MPO. Also, oral drugs may be result in aspiration and choking in patient with low level of consciousness. In such cases, IV route it will be preferred. Okay, what are the materials required for IV cannulation? We will need dressing tray, non-sterile gloves, gauze pieces, alcohol swab, tourniquet, IV cannula with appropriate side, dressing to secure cannula, saline flash and sterile syringes, or fluid to be administered and sharp container. This is the sizes of the cannula. It will depend on the size of the vein and the depth also of the vein. Okay. Before the procedure, you have to introduce yourself to the patient, give explanation, and you can also gain consent. Then the patient should be positioned comfortably, preferably lying down, and check if there is any contraindications for insertion like infection, tissue damage, or if IV fistula is in place. Then wash your hand, prepare your equipment needed, take the cannula from the packing and check that all parts are functional, and then apply your non-sterile gloves. Then, how you will insert the cannula? First, apply the tourniquet. The tourniquet should be applied correctly at the upper arm and the pressure which is high enough to impede the venous distension. Then identify the suitable vein. This is the commonly accessible veins, the cephalic vein, basilic vein, and the median cubital. And also we can use the metacarpal veins. After you will choose your vein, how you will choose it? You have to choose the good vein, which is bouncy, soft, refills when depressed, visible, easily palpable, and straight. And also there is some veins that you have to be avoided, which is thrombosed, inflamed, bruised, thin, fragile, mobile, or the one near to the bony prominences and areas of infections, edema, or phlebitis. Then clean the site over the vein with alcohol swab and wait until to be dry. Then hold the cannula with your dominant hand. Stretch the skin over the vein to anchor the vein with your non-dominant hand. Then insert the needle with the bevel side up at the angle of 10 to 30 degrees to the skin. This it will be depend on the depth of the vein. Now gently push the cannula over the needle while you withdraw the guide. Attach the white lock cap, then apply gentle pressure over the vein beyond the cannula tip. Then remove the needle from the cannula, release the tourniquet, and secure the cannula with appropriate dressing. The complications from IV cannulation or IV access, could be local or systematic. Local, it may cause cellulitis, hematoma, thrombosis. Systematic, may cause sepsis, pulmonary thromboembolism, catheter fragment embolism, and air embolism. Now, we will move to the intraosseous access. What's the intraosseous access? It's a placement of a specialized, rigid, hollow bore needle through the cortex of the bone and into the medullary space for infusion of medical therapeutic agent and also for laboratory testing. Why? When we will need to use the IO access, it's recommended in the emergency cases like in cardiac arrest or in trauma, and in some cases in decompensated shock. Intraosseous access should be established if the vascular access is not rapidly achieved, if other attempts at venous access fails, if they will take longer than 90 seconds to carry it out. The contraindication of it, if the patient having osteogenesis imperfecta, because maybe it will cause fracture at the site of the insertion, adequate venous access if there is already IV access before, fracture of the bony sites of access, burn site, cellulitis or infection at the same site of insertion, previous IO attempted site. The site of intraosseous insertion, proximal tibia, which is preferred site during emergency cases, distal tibia, and distal femur. The equipment we will need antiseptic solution like alcohol, chlorhexidine, povidone, and intraosseous needle or insertion devices or drill, syringes 5 or 10 ml, sterile saline or 4 flushes, IV connection, tubing, and dressing. Insertion. As we said before, in the emergency cases, the most common site for the insertion will be the proximal. The insertion is the proximal tibia. First of all, we will clean the area with alcohol or with the chlorhexidine. Then we will find the tibial tuberosity. Then we will go approximately 2 centimeters toward inner leg. Then approximately 1 centimeter toward the knee. It will be the penetration site. Then we place the needle through the skin. Either we will activate the drill until the needle will uncross in place, or even we can use it manually, 90-degree clockwise with gentle firm pressure without pushing. Then we will stop advancing when we will feel decrease in resistance. That means the needle is already in the site or in the place. Then after we will be confirmed that the needle is in the place, we will remove the stylet and we will attach the syringe. After we will attach the syringe, we will aspirate. Presenting of blood or bone marrow will confirm us that we are in the correct placement. After that, we can secure the IO with the dressing and we will attach the tubing. The duration, the intraosseous access, it will be valid up to 24 hours. We can use it. Any complication? Yes, there is complications of using intraosseous. It may cause fracture, more deep insertion, infection, air embolism, PE, allergic reaction, thrombophlebitis, and infiltration outside.